We're talking with Dr. Keith Woodward, and we've been talking about interventional neuroradiology, about if somebody has a stroke, you can actually go up in the appropriate artery, way up even to the back of the brain, and can remove a clot that allows a patient to have normal blood flow to re-nourish the brain. You and I were talking about a story about someone's speech when you were fixing a clot like that. Tell me that story.
Yeah, so he was having what we call the ischemic stroke, or a blockage, where there was a clot blocking the artery on the left side of the brain, and that controls your speech, your ability to make the words or know which words to say. And so he could not speak at all. And you ask him his name and he would just look at you. And so went in from the groin, able to get a little catheter up there, did that little suction embolectomy or suction to pull the clot out. And as soon as the clot came out, I knew I had the clot. As I was pulling out, I said, "Tell me your name." And he looked at me and he said, "My name is," oh my gosh, I can talk again. And then he started crying. He was so emotional. It was really a powerful moment for me personally, and a great case. And we see that more and more commonly, especially if the patient can get to the hospital quick enough.
Yeah, that's the key, and that time is brain.
It is, yes.
So if you can get to the hospital quickly, you can save brain by reestablishing the blood flow. Is that now? We put the little suction in there, and we sucked out the clot, and you can sort of feel it dislodging. What's the other way that you have of removing a clot?
So if it's a hard rock type of clot and I can't get it to come out that way, we have a little device that looks like a little basket, and I take it up past the clot, and then I open that basket, and it catches the clot and pulls it out as I pull the wire back.
Is that a more dangerous or difficult procedure than this getting up to a suction?
It's a little more difficult because it's a stiffer device, and so it can bend the arteries a little bit, and you may be more likely to have problems with that. But in all, they're pretty safe procedures.
And when you reestablish the blood flow, how does that make you feel when you see a patient talk, when you see them lift their arm, when you say they can then even see that if certain arteries are affected?
I feel like I've been blessed with the best job in the world.
Yeah.
I really do.
Yeah. If I've got time, maybe I could go back and be a neurointerventional radiologist.
There are hard times too, for sure. But
So let's talk about some other things that you do. This is the removal of a clot in somebody that's having a stroke. So we've got to recognize by FAST, facial asymmetry, one side droops, an arm being weak, speech being garbled or improper. So tell me about other procedures you do other than getting an ischemic stroke.
Sure.
removed.
So we talked about ischemic versus hemorrhagic, where an artery is blocked versus where it's bleeding. It's kind of like I'm a brain plumber. Pipes are either blocked or they're leaking. So a leaking pipe is a totally different problem with different solutions that we can give.
So what causes the pipe to leak, the blood vessel to leak?
The very common things are high blood pressure, but aneurysms are also a very common cause of bleeding.
So what is an aneurysm, and are these aneurysms in the brain we're talking about?
Yes, so an aneurysm in the brain, imagine a weak spot on a tire where it starts to bulge out a little bit. That's what an aneurysm is. It's the artery wall has gotten weaker, and over the years it starts to bulge out. These grow over several years. They don't pop up overnight. But when they reach a point where they become too weak, they can burst, and then they bleed. And that's a big problem.
And then you've got a big problem.
Then we have a big
So
problem.
if you find out that somebody's got an aneurysm, what does the interventional neuroradiologist do?
Right. I put on my other hat, and now I'm going to go try to close that artery. And so I take the catheters we talked about, same type of catheters, run those up into the neck, and then using that same camera, guide my little catheter right up inside that aneurysm, and I can fill it up with little platinum strings.
How big are those little aneurysms?
Those little aneurysms can be down to 1 millimeter.
A millimeter, so that's
Tiny.
That's tiny, tiny, tiny. So you can get, and you fill it up with the coils, or what do you do?
I have these little strings. They're 10,000ths of an inch thick. They're so tiny, and when I advance those up, it fills it up and seals it off. I also have little stents I can put across the aneurysm to shut it down, and little baskets I can open up inside the aneurysm to close it off. The goal is just to stop the blood flow inside that weak spot and let the artery heal.
So what you're doing is preventing the weakness in that artery from getting so weak that it bursts and bleeds, and then you got big trouble. So you can put the finger in the dike in the dam,
right. Yes.
And stop that from occurring. Are patients symptomatic? How do they know if they got an aneurysm?
If they have a ruptured aneurysm, the classic explanation is it was the worst headache of my life.
Yeah.
When I have someone who has survived a ruptured aneurysm and once they've kind of recovered, tell me what happened, they can say, it was 3:42, I was reaching up to pick up a basket, and then all of a sudden the worst headache of my life. There's never any doubt, do I have a headache or not? They know when it happens.
Yeah.
Something really bad has just happened.
We used to call those a banger.
Yes.
Somebody that, it just was terrifying.
Yeah.
If somebody has one aneurysm, do they usually have 3 or 4 somewhere else up in the brain?
About 15% of patients have a second aneurysm somewhere.
So
we look closely to find those others as well.
And you go find them and you fill the aneurysm up with these little threads, these little coals, let it heal up, and the patient lives happily ever after.
That's correct.
Anything else the neuroradiologist does, the interventional radiologist?
So we're also key in detecting those strokes. As we talked earlier about how important it is if you see someone having a stroke to get them to the hospital, it's just as important for when you get to the hospital for me to know as quickly as possible that there is a blockage in that artery. I know we talked a little bit about the AI, the artificial intelligence, and that is a system we put in at Vista Radiology that has a computer looking at those scans. The moment that scan is done, that CTA is done, the computer's looking for that clot. And when it finds it, it wakes me up in the middle of the night. Alarms go off and I get the call that there's a clot somewhere. So now I can find these much, much faster than I could just 5 years ago.
Isn't that amazing? Because as we said, time is brain.
That's right.
So this allows you to get to where you need to fix it much quicker.
That's right.
Gratifying part of medicine?
Again, I think it's the best job in medicine.
Yeah, I can see that in your face, and I can see how that would be somebody that's in a life-threatening situation, that what you can do is make them into a very functional person. Is there a follow-up that you do on patients that have had a stroke or that have had aneurysms? Do you have to re-x-ray or redo something later on?
So the thrombectomy we talked about, pulling that clot out of that blocked artery, those patients, typically the next step is just figuring out what caused that blockage and treating them. Maybe they have AFib, arrhythmia of the heart, and that caused that blood clot to break off and go to the brain. So we have to treat that separately with a blood thinner. But typically we don't follow those patients because preventing another stroke is just finding the cause and treating that. The aneurysms, on the other hand, we do watch those because A, they can get new aneurysms in the future, and B, sometimes those aneurysms can try to come back. It's very rare, but we watch them for about 3 years. We know after about 3 years they don't come back when they've been coiled or closed off.
And when they come back, is there any difference in treating it?
It's usually easier to treat it when it comes
Second
back.
time. Yeah. Keith Woodward, you're a great teacher. I've loved this show. I've loved learning. You're a great teacher. You've been able to teach us the new advances that can save people's life. And what a great feeling that must be. You probably do have the greatest job in medicine.
Thank God. I think I do.
Wasn't that fabulous? You're going to want to stay tuned. We're going to be talking about the adrenal gland. Where is it? What does it do? What does it do to protect you? It does a lot. And what are the dangers of atrial fibrillation? And what is atrial fibrillation? It can be dangerous in several ways. We'll talk about those and learn about those. You'll want to stay tuned.